Okay, good afternoon, everybody. This is hopefully not going to be quite as intense and scientific as we had this morning, because it was quite a lot of concentration was required this morning, although it was really, really interesting. 4 years ago when I did this talk, we just took a little bit of time to think again about inheritance patterns and think about recurrence risks and choices around family planning. The way in which I've structured the talk is really mostly about families who have had a child affected by the condition who are thinking of having more children. But of course, a lot of the children are growing up now and they might actually themselves be planning on having children. So if you do have questions about the children's options regarding having children themselves as they become teenagers, as they become older, I'd be happy to try and answer any of those questions, but I haven't specifically addressed it in the points that I was going to go through now. So these are things you've already heard about this morning. You've had introduction, particularly from Johan, but actually everybody, including Carsten, has talked about inheritance patterns and different genes that can be associated with centronuclear myopathies. What I'm just going to do is run through again as a refresher, and each of you may have a certain amount of knowledge, of the three most common forms of inheritance: X-linked recessive, which is the main one, autosomal dominant and autosomal recessive, just to remind us about those. And underneath each type of inheritance pattern there, I've listed the most common genes, but as you've learned already this morning, there are actually a lot more genes involved in causing this condition. Most of the additional ones are autosomal recessive, but some of them are dominant as well. So we talk about autosomal recessive and autosomal dominant, and we talk about X-linked. So the reason we use these terms is because we carry all our genes on chromosomes. Our chromosomes are packages of all the 20,000 genes that we have. And we've got 23 pairs of chromosomes. And for each pair, you get one from your mum and one from your dad. Pairs 1 up to 22, we call those the autosomes. So you can see that's written on the bottom of this slide. So those are the autosomes. So any gene alteration that occurs on one of the autosomes is going to have an autosomal pattern of inheritance. So that might be autosomal recessive or autosomal dominant. And we'll look at those again in a minute. For X-linked recessive inheritance, we're talking about the 23rd pair of chromosomes, which is the sex chromosomes, which determine whether you're going to be a boy or a girl. And the sex chromosomes on this slide are an X and a Y, so a boy. Girls have got 2 X chromosomes and no Y chromosome. So X-linked conditions are caused only by genes that are carried on the X chromosome. So if we start with X-linked recessive inheritance, and Carsten Bonneman referred to this condition, and he showed you a diagram very similar to this earlier. When we use the word recessive with X-linked, what we mean is that generally speaking, it only affects boys and it doesn't affect girls. But as Carsten pointed out, actually women who are carriers for this condition may also show symptoms to some degree. So in these diagrams that we use in genetics, we use squares for male and circles for female. And when we denote somebody's affected by the condition, we colour the shape in. And when we denote that somebody's a carrier, we usually do a small little dot in the middle. So what you can see in this picture is that the man is XY. He's healthy because he's not coloured in and he doesn't have any genetic condition. His wife or his partner has got a little dot in the centre of her circle. She has one X chromosome that is healthy, and then the other X chromosome is carrying a mutation in a gene that's carried on the X chromosome. And that's denoted here by the little upside-down triangle that you can see. So we can say that she's got 2 X chromosomes, one carrying, in this instance, an MTM mutation, and the other one not. So when you look at the combinations that that couple can have, you can see that the dad is only going to pass on either the X or the Y. The mum is only going to pass on either the X or the X that's carrying the mutation, so the one with the little triangle. So the first combination is the empty square that's not coloured in, which says XY. So that boy has got X, healthy X from his mum, and the Y from his dad. So the dad is always determining the sex of the baby. In the next one, an unfilled circle, we've got 2 X's, and that is the healthy X from mum, but also the X from dad, dad determining the sex of the baby. Then the third one is a square that's coloured in blue, and that's the boy who's got the condition, and he has inherited the Y from his dad to make him a boy, but he has inherited the other X from his mum, the one that is carrying the MTM mutation. And then the last combination is when dad has it's a girl again, dad passes on his X chromosome, and on this occasion, mum passes on her X that is carrying the mutation. So it's a girl who's a carrier, just like the mum. So there's 4 different possibilities, each time with an X-linked recessive condition. So usually we say that because the carrier women have got one healthy copy of the gene, they don't show any symptoms. But there's a bit of variability in that, and that was explained by Carsten earlier today. So for a boy, it's 50-50 whether he gets the X that's carrying the condition from his mum. So we've gone through actually the combinations there, but just to summarize it, for carrier mothers, they have a 25% risk of having an affected son, a 25% risk of having a carrier daughter, 25% chance of having an unaffected son, 25% chance of having a non-carrier daughter. Now that's when the mother is actually a carrier, but what can also happen in X-linked conditions is actually the genetic condition can appear to arise in the boy that's affected for the first time. We use the word often de novo mutation, or something that has started at that child's conception. So in that situation, we identify genetic change in the boy, show that he's got myotubular myopathy, and then test the mother, and both her MTM1 genes on both her X chromosomes appear to be healthy and normal. So then sometimes the question comes, well then does that mean there's no risk of her having another boy affected by that condition? But there's a concept of something called germline mosaicism, which means there might be a slightly increased risk, and that means that even though you can't find it in the mum's blood, it is possible that in her ovaries she could carry some other eggs that actually carry that same genetic change. So there's a small possibility, often we say 1% or less, that she might have another boy affected by the condition. Okay, so if we go on to autosomal dominant inheritance, I'm not sure how big that diagram is. Probably big enough to see. So in autosomal dominant inheritance, and we were taking the Dynamin 2 mutations here as the example, in this situation, it's an autosomal condition because it's on, I think it's chromosome 19. So you have a chromosome 19 from your mum, a chromosome 19 from your dad. So you've got 2 copies of the Dynamin 2 gene. And in this situation, one of those 2 copies has got a mutation in it. And in a dominant condition, what can happen is even though you've got another healthy copy of the gene, actually that's not enough to stop you from developing the condition. So in this diagram here behind me, there's a picture of a man who's got an A that's in black and then an A that's in blue. And for the woman, there's 2 A's in black. So the A that's in blue is representing the genetic condition. So he carries the genetic condition, he has the genetic condition. And if we look at the different combinations that you can have there, you can have the father passing on the A that doesn't carry the mutation with one of the A's from mum, that's a child that's not affected. You can have the father passing on the A that is blue, which is carrying the mutation, with one of the A's from the mother. And even though there's 4 different combinations, actually the end result is a 50-50 chance of transmitting the condition. So the thing about dominant conditions as well, it affects males and females equally. The other thing about them is that they're more prone to variability in expression. So even in a family with a number of people with the same genetic change, you can see variability in how it affects them. It's not always exactly the same. So any questions about dominant inheritance? Was that fairly clear? So the last one is recessive inheritance. And again, I'm using my diagram here with the squares for men and the circles for women. And this time, rather than drawing chromosomes or X's and Y's, what I've got is, again, on the autosomes, I'm taking bin1 as being our example, or amphiphysin 2 is the same gene. You have 2 copies of that gene because it's an autosomal gene. It's on chromosome 2. And so you have 1 chromosome 2 from mum and 1 chromosome 2 from dad. And what you can see in the dad and the mum here is that each of them has got a gene that's coloured in blue, and each of them has got a gene that's coloured in white. So they're carriers. But the difference here is that if you have 1 working copy of the gene, you're still healthy. And that's different in recessive inheritance. So they're both carriers and they're both healthy, and they wouldn't even know that they're carriers for this condition. We're all carriers for lots of recessive things, and we're not aware until potentially we have a child with somebody who's also a carrier of the same thing. So if we do the combinations here, and we do the blue circle from dad and the little blue circle from mum, that's 2 coloured in blue circles, and that's an affected person who's got the condition. If we take the blue circle from dad with a white circle from mum, that's a carrier who's healthy. The other way around, we take the white circle from dad and the blue circle from mum, that's somebody who's unaffected. Or we take the 2 little white circles, and that's a child who's not affected and not a carrier. So what you can see is there is a 1 in 4 chance, or a 25% chance in recessive inheritance of having a child who's affected by the condition. Just as an aside, what we then say is for siblings, brothers and sisters, of a child who's been affected by a recessive condition, what's their chance of being a carrier? And you can see that if they're not affected by the condition, which usually is clear in recessive disorders because most of the time they tend to be that bit more severe, and you're unlikely to have a very mild form of it, which can happen in dominant conditions. So there's 3 other possibilities left. The 2 carriers and the 1 who's not a carrier. So for a sibling, the chance of being a carrier is 2 out of 3. So quite a lot of the time in practice as a clinical geneticist, the diagnosis has actually been made and the diagnosis is understood. There's actually a genetic test available that confirms what the cause of the condition is in the affected child or member of the family. And the question can then arise, well, what is the risk then of having another child affected by the condition? Now, depending on the condition and the severity of it, some people would want to try and sort of restore reproductive confidence and try and avoid to have another child affected by the condition. Not everybody takes that view. So, and some people, their religion, means that they're just whatever happens, happens. But so those are important factors, but there are options available. And so what I was going to do, take you through some of those options. So the 2 main things I'm going to cover are testing in a natural pregnancy, and you can either do that by a chorionic villus sample or by an amniocentesis, and I'll tell you a bit more of those in detail. Or more recently, there's the availability of something called pre-implantation genetic diagnosis. So that's using IVF to try and help. So this diagram here is showing a woman's tummy taken from the side, and you can see the bones of her spine at the back there, and you can see a small little fetus growing inside the womb, and then you can see the white ultrasound probe scanning the baby. And what you can see between the fetus and the ultrasound probe, you can see the big placenta. Oops, pressing the wrong button. So that's the placenta, and that is what gets biopsied in chorionic villus sampling. It can be done just after 11 weeks of pregnancy. People wait until then because it's thought that doing it any earlier than that is a little bit unsafe. The risk of the procedure causing a miscarriage is generally quoted to be 1 to 2%, but in centres where they do it an awful lot, the risk may be well below that. It may be even less than 0.5%. So what they do is they put a needle, a very fine needle, under ultrasound guidance into the placenta and take a very small biopsy. And in the placenta, there's cells from the mother and cells from the baby. They're able to be separated out and analyse the baby's cells to see whether the baby has or has not inherited the genetic condition in question. There are some limitations to the test. Sometimes it doesn't work, or occasionally maternal cells can contaminate it. That only matters if the mother is the carrier of whatever the genetic condition is. But usually it's a pretty reliable test. The test of amniocentesis is slightly different. It's done a little bit later, at about 15 to 20 weeks of pregnancy, and this involves taking the amniotic fluid. So rather than taking a biopsy of the placenta, you're just taking fluid from around the baby. And in the amniotic fluid, you've got cells from the baby that have come from the bladder, because the amniotic fluid, a lot of it is made from the baby peeing, if you like, or weeing. And so cells from inside the bladder come out into that amniotic fluid, as well as skin cells coming off from the baby's skin. And so those are the cells that are analysed. So they're thought to be very clearly a representative of the baby's genetic makeup. This test is only available a little bit later because there isn't enough amniotic fluid early on, and it's said to be associated with a slightly lower miscarriage risk than CVS, it isn't complicated by the problem of maternal cell contamination. The purpose of doing these tests early on in pregnancy is really only whether people would consider ending that pregnancy because they don't want to have another affected child. And this is, things that is considered for lots of different conditions. So it is an option that is there. The fact that there is a risk of the procedure itself potentially triggering a miscarriage does trouble people, especially, of course, if it's a healthy baby and just having the invasive test causes that pregnancy to be lost. So quite a lot of effort is done to try and modify the risk of that baby actually being affected. So really to be only doing the invasive test that can trigger a miscarriage if it's thought is really, really needed. So a test became available, and actually when I was talking here about in 2014, it was available at that time as well, called free fetal DNA testing. And this means that you're actually able to take a sample of the mother's blood and identify some of the baby's blood or DNA within the mother's blood. And this has become more and more sophisticated, but the main way in which it has been used when it started out was to just determine whether the mother was carrying a male baby or not. There are lots of different X-linked recessive conditions which can be very severe, and so it was felt if you could modify the need to do an invasive test by only testing the pregnancy when you knew the mum was carrying a boy, that this would be helpful. So at about 9 weeks of pregnancy, it's possible to take a sample of blood from the mother and determine if there's any male DNA in her blood. And that can tell you she's carrying a male pregnancy, and then proceed with the tests that we've already discussed. This is just a picture showing a little bit more about the same thing, and we've got in green there, those are red blood cells circulating around the mother's blood. In green is the mother's DNA, in blue is the baby, the fetal DNA, and you're able to pick that up. So this just comes to the end, and this is about pre-implantation genetic diagnosis. And in this, for some couples, they would really like to avoid having another child affected by the condition, but having a termination of an established pregnancy is something that they really feel they're unable to do. In this, you go through IVF, so in vitro fertilization technique, where the mother is treated with hormones to stimulate her ovaries to produce a number of eggs. Those eggs are what is said is harvested, but they're taken out of her ovaries, and then they get fertilized with the father's sperm, so that you have an embryo. And the embryo is then grown in the laboratory to a stage where it's got 15 or 20 cells. And then one of those cells is taken out of that embryo to double check whether the fetus or the embryo has inherited the genetic condition or not. And then only embryos that are not at risk of having the genetic condition are put back in the womb for implantation. And in that way they can be confident that the baby is not going to develop the condition. This here, talking in terms of UK practice, is available on the NHS for severe conditions. There are conditions that have to go through a process of being licensed for PGD. And so you can have 3 cycles of IVF if you don't have any healthy children and try this PGD process. But it's also available privately, and it is quite expensive, about £12,000 to £15,000 to do it. So I think those are the main things that I wanted to say, but obviously want to give time for people to ask questions.